Hi, I'm Amanda,
I'm Natalie.
I'm Becca.
And I'm Leanne.
and this is Polypharmacy in Geriatrics. So what is polypharmacy? Polypharmacy has a lot of different definitions, but we can generally describe it as the use of multiple medications, generally referred to as 5 or more prescribed drugs per day, and/or the administration of more medications than are clinically indicated, representing unnecessary or unwanted drug use. So what does this look like? Well, globally, an average of 2 to 9 medications are taken daily by elderly people. The elderly population makes up less than 13% of the US population and makes up 33% of annual prescriptions. In Americans 60 years or older, over 76% use 2 or more prescription medications, and 37% use 5 or more. So that's 37% of Americans 60 years or older that meet our very baseline definition of polypharmacy. So what are the effects of polypharmacy? The effects of polypharmacy are far-reaching and diverse, so to generalize it, I've put together a few statistics here. So inappropriate medication use is seen in around 11.5 to 62.5% of the elderly population. And inappropriate medication use can include anything from inappropriate dosing, timing, actual medication, etc. 1 in 6 hospital visits in the elderly population are due to adverse drug events, and the cost of polypharmacy is estimated at more than $50 billion annually by the U.S. Center for Medicare and Medicaid Services. So in order to better understand polypharmacy today, we're going to introduce a case example here, and then as we go through the risks and effects of polypharmacy, as well as how providers, caregivers, and patients should handle polypharmacy, we're going to revisit this case. So patient SJ is a 74-year-old man with a past medical history of hypertension, COPD, type 2 diabetes, anxiety, and a myocardial infarction in 2017. He smokes 1 pack per day and denies frequent alcohol use. His home medications include lisinopril, atorvastatin, metformin, semaglutide, citalopram, Stiolto Respimat, and albuterol as needed. SJ is admitted to the hospital with new onset heart failure. While in the hospital, he is started on metoprolol succinate for heart failure, furosemide for edema, omeprazole for stress ulcer prophylaxis, and nicotine 7 mg patch for nicotine withdrawal, and his lisinopril dose is increased. Once SJ is stable, he is discharged on these medications and has a follow-up with his primary care physician in 7 days.
So like Amanda said, we're going to keep patient SJ's case in mind while going through the risks and adverse effects of polypharmacy. The first risk we're going to look at is prescribing cascades. And these can occur when signs and symptoms of adverse drug events are misinterpreted as disease. And as a result, a new drug therapy is added to the patient's regimen. So adverse effects are very common with OTC and prescription medications, and the elderly are more at risk for adverse effects. And this can be due to the natural effects of aging, such as changes in volume of distribution, changes in metabolism, and changes in the clearance of drugs. And it can be hard to recognize these adverse effects as they can oftentimes be nonspecific and include things such as cognitive impairment, confusion, and falls. Lack of adherence increases dramatically with the number of medications prescribed. So if a patient is experiencing an adverse effect of a drug, they may decide to discontinue or dose reduce their own medications without consulting their pharmacist or healthcare provider. Additionally, taking many medications can be very confusing for anyone, and this can lead to forgetfulness. And this can cause patients to either skip a dose or even potentially double a dose. And when patients have multiple caregivers, this can just add to the confusion. So if a patient isn't adherent to their medications, this means that they're not being optimally treated. So if a patient is not adherent and their prescriber evaluates them, they may decide to increase their doses or prescribe new medications when really the patient might be controlled if they were just taking their medications appropriately. The last risk we're going to talk about is an increased risk for drug-drug interactions. And we have to watch for these with prescription medications, over-the-counter medications, and any supplements that the patient might be taking. So two types of drug interactions are pharmacodynamic and pharmacokinetic drug interactions. For pharmacodynamic interactions, an example of this would be if a patient is taking a beta-2 agonist inhaler for their COPD and are also put on a non-selective beta blocker for their heart failure. So you have one drug that's agonizing the receptors and another drug that is antagonizing the same receptors, which can lead to a reduced effect on both ends. And an example of a pharmacokinetic drug interaction would be if medication A is metabolized by a certain CYP450 enzyme, and medication B is an inhibitor or an inducer of that enzyme. So if medication B inhibits the CYP450 enzyme, then this can lead to an increased concentration of medication A in the patient's body and potentially increase more adverse effects. So looking at patient SJ, he's now taking 11 medications at home, which I'm sure can be very confusing for him, theoretically. And we're going to look at a few of the medications that he was sent home on. He was sent home on nicotine replacement therapy, which was started in the hospital because he cannot smoke in the hospital. But there's no at-home indication for this because he can just go back to smoking cigarettes. The nicotine replacement therapy has the potential to increase his heart rate and blood pressure, which can worsen his cardiovascular health. Looking at omeprazole, similarly, there's no at-home indication for this. He was started on it for stress ulcer prophylaxis, but that's no longer a concern for him being discharged. One of the risks of omeprazole is that it can potentially increase his risk for C. diff infection. And lastly, we're going to look at a drug interaction. The omeprazole and citalopram that he's now currently taking can interact with each other. And the omeprazole can cause an increase in the side effects of citalopram for patient SJ. So looking at some of those adverse effects of polypharmacy, they can include decreased functional status and ability to perform activities of daily living. And activities of daily living can include things like feeding, grooming, and dressing that many of us are able to do ourselves every day. And this decreased functional status can increase the mental toll on both patients and caregivers. Similarly to that, increased cognitive impairment can include both delirium and dementia and can once again increase burden on both patients and caregivers. The elderly are already at an increased risk of falls, and polypharmacy can increase that risk even higher. And this can lead to a risk of both morbidity and mortality for these patients. And lastly, polypharmacy can lead to a loss of appetite or GI issues that can cause a decreased nutritional status for these patients, which can lead to a decrease in overall health. But there can be some challenges in identifying problematic polypharmacy. Problems due to medications may appear as normal symptoms of aging, as alluded to before. So this can be things such as weakness, constipation, and blurred vision. Additionally, adverse drug reactions may present differently in geriatric patients than they do in young adults. So this can make them hard to identify. And lastly, there's the hesitancy to deprescribe in geriatric patients and fear of destabilizing their health. So looking back at patient SJ and his potential adverse events, these are just two examples of things that can hypothetically happen to him, but not that are for sure certain for anyone who takes these medications. So if patient SJ was discharged on that nicotine replacement therapy and it did increase his heart rate, then at his PCP follow-up appointment, his provider could potentially increase his carvedilol dose to try and decrease his heart rate. This increase in dose would put SJ at a higher risk for hypotension and falls. Additionally, looking back at that omeprazole and citalopram drug-drug interaction, like we said, omeprazole increases the side effects of citalopram. One of those side effects is insomnia. So if SJ begins experiencing increased insomnia, then he could potentially report this to his provider and be prescribed another medication, which leads to a prescribing cascade. Or maybe SJ could decide to treat it on his own. So if SJ hears from a friend that over-the-counter Benadryl can make you drowsy and help you fall asleep, and it works for him like a charm anytime he needs it, then maybe SJ can try this out for himself. SJ could potentially start experiencing anticholinergic side effects from the Benadryl, and this can once again lead to another prescribing cascade.
So, with all of these risks of polypharmacy, there are some guidelines that can be used by both prescribers and pharmacists to safely manage their polypharmacy patients. The first tool I'm going to talk about is stop and start criteria. This criteria suggests drugs to avoid and drugs to use in the elderly population. So, with stop criteria, it stands for Screening Tool of Older People's Prescriptions, and it provides a list of medications organized by system in the body, such as the cardiovascular or gastrointestinal system, that may be inappropriate for patients over 65 years old. The START criteria stands for Screening Tool to Alert Doctors to Write Treatments, and provides a list of medications that are appropriate for patients over 65 and should be considered by prescribers. Another tool is the Beers criteria. So the Beers criteria is provided by the American Geriatrics Society. It includes guidelines for healthcare professionals to help improve the safety of prescribing medications in older adults. It lists medications to avoid in the geriatric population and is organized by drug category, disease state, and drug-drug interactions. Beers criteria suggests high alert medications in high alert patients that need to be treated with caution. Some high alert medications to watch out for include anticholinergics, NSAIDs, benzodiazepines, fluoxetine, tricyclic antidepressants, oxybutynin, warfarin, and digoxin. High alert patients include those with impaired renal function, impaired cognition, patients prone to falling, diabetes patients, Parkinson's patients, hypotension, and malnutrition. So like Leanne said, malnutrition is dangerous because the elderly are already at risk for having decreased appetite or malnutrition. And if a patient is on medication that may also further decrease their appetite, this can lead to a decrease in overall health. Another tool that can be used to address polypharmacy is Cancel RX. So Cancel RX is a program that allows prescribers to electronically discontinue a prescription they previously wrote for a patient, and Cancel RX is used through the patient's electronic medical record. And this program helps to prevent unnecessary refills. So Cancel RX can be used in two ways. One way is if the prescriber wants to discontinue a medication therapy that is still active or has refills left. So a prescriber may do this if they feel the therapy is no longer appropriate or they just no longer want the patient to be taking it. And another way is if the prescriber wants to correct a mistake on a prescription they sent to a pharmacy, they can use Cancel RX to rescind that prescription and send a new one. So pharmacists have a huge role in preventing and managing problematic polypharmacy. Some risk factors for problematic polypharmacy occurring within your own practice site as a pharmacist can include the use of automated refill systems. So these systems can make it hard to catch prescriptions that may not be appropriate to fill anymore. It can be caused by doctors prescribing to meet metrics, poor transitions of care, and unreliable patient history, such as when you cancel a patient, they may forget to tell you that they take certain over-the-counter medications or supplements. And if problematic polypharmacy does occur at your practice site, there are some negative consequences, and these include decreased quality of care for your patients, increased medication errors, workflow impairment for both pharmacists and technicians, and then decreased productivity of the pharmacist when they have to correct those medication errors. It's really important for pharmacists to be proactive in preventing unnecessary polypharmacy in their patients. And there are a few ways they can be proactive. First, they can do face-to-face patient counseling on any new medications to ensure the patient understands what they're taking. Pharmacists can do medication reconciliation, which means obtaining an accurate list of all medications, supplements, or OTC products your geriatric patient takes. They can use stop and start criteria and also Beers criteria, which I just talked about. And they can also perform medication therapy management services, which includes medication therapy review, medication-related action plans, intervention or referral, and documentation and follow-up. So going back to patient SJ, pharmacists can catch problems in their polypharmacy patients through medication and reconciliation and counseling, like I was just saying. So with patient SJ, if we did medication reconciliation at discharge, we could have caught him being on omeprazole and nicotine patch still and discontinued them before he went home. And this would prevent unnecessary medications. A hypothetical situation that could also occur is if SJ does start taking the Benadryl to combat the insomnia from his citalopram, he would then be taking an anticholinergic, which is a high alert medication class on Beer's criteria list, and this would avoid any problems with his health.
Diving a little deeper into the importance of counseling patients on both OTC, prescription, and supplement medications, I'm going to go into some points that are important to make to a patient. So polypharmacy doesn't just involve prescribed medication. OTCs and supplements are just as important to pay attention to as prescription medications. Pharmacists in the community setting are in a position to intervene with OTC polypharmacy too. So before treating a symptom or ailment in the community setting, it's important to ensure that the OTC a patient is choosing is appropriate for what they're feeling. Each OTC product packaging contains something called drug facts. This tells you exactly what you need to know about that specific drug. I've highlighted 3 main sections of the drug facts label that I think are the most important to help eliminate polypharmacy, but this part of the packaging is pretty inclusive and can answer most, if not all, questions that patients might have on an OTC product. So it's important for a pharmacist to make sure that the patient understands what these mean. So the 3 that I've highlighted are: first, contraindications and drug interactions. This will be printed right on the packaging if an OTC has an interaction with a prescribed medication. This is important to eliminate something like Leanne was talking about before, drug interaction that could induce greater side effects for a patient. We also want to pay attention to the active ingredients to make sure you're not taking duplicate therapy. So if you're taking a combination product that already has acetaminophen in it, you wouldn't want to take just plain acetaminophen. And lastly, I think it's important to pay attention to the indication because you want to make sure that what you're using is actually going to treat what you're feeling. It's also important to counsel the patient on staying organized. So I've listed a couple ways to help keep a patient organized. Pill boxes help patients to stay the most organized because they manage their meds in a way that eliminates doubling a dose, skipping a dose, confusing one medication with another. And I think for someone like SJ, when there's 11 pills to be taken in a day, it keeps it very mapped out and organized. In addition, lists never go out of style and are a very traditional and effective way to make sure that a patient and provider have the same up-to-date list of medications, their doses, and when they're taken. Lastly, I think adherence techniques have taken a technological advance because there are many apps that help patients to remind them to take their medication. I think it's important that pharmacists familiarize themselves and patients with what's available because smartphones are commonplace even in the geriatric population, and I think these apps are very useful in making sure that patients are reminded and adhere to their medication. Going back to patient SJ, there are some counseling points that definitely would benefit him. SJ can keep a pill box for his 11 medications. This is just a super effective way of keeping them organized and preventing confusion between the different pills and capsules. SJ should keep an updated list of his current prescriptions and OTC medications. This is something he should bring with him to all of his doctor's visits. We should also encourage SJ to talk to his pharmacist or PCP before self-medicating. This pertains to the issue with taking Benadryl to help him sleep, all because of a drug interaction between two prescription drugs. And then again, the adherence techniques. We want to make sure that the patient is getting the most out of their care plan and that it's actually effective because they're taking their prescriptions right. And lastly, just a note to patients and caregivers. Communication is so important in making sure that patients and providers are on the same page to ensure that their care plan meets their personal needs. So I like to emphasize that we shouldn't be afraid to talk to our doctors or pharmacists about concerns regarding medication regimens or treatment plans. We want to look out for common symptoms of adverse reactions and drug interactions resulting from polypharmacy, some of the things that Leanne listed earlier. We want to be proactive and involved in our healthcare. So, like Becca said, it's important to just stay on top of it and be integrated with your healthcare providers. Ask questions to better understand both prescription and over the counter treatments. And remember that your pharmacist is the most accessible healthcare provider, and no question goes unanswered. These are our references. If you have any questions, please feel free to reach out or fill out our question and answer survey. And we thank you for listening.
Yay. Good job, guys.